Well, Namkri Nangi, everyone. Nanawamichi Paul Worley. I work here in Pomerunk, Murray Bridge, which is Ngarrindjeri Rui. And I'm very proud to be able to work on this country that has been undertaking health care, health research and health education for 60,000 years, and to build on that heritage that is ongoing with our Aboriginal people here. Welcome to the Riverland Academy of Clinical Excellence Grand Rounds, an opportunity for us to hear from experts around the world, to learn and to collaborate with people who are making a mark in rural health in particular. For those of you who've been to our rounds in the past, you'd know that rural generalism is a common theme of what we're doing, because in the medical sphere, they are the core component of our medical practice, and increasingly in allied health and nursing as well, the concept of rural generalism is important. Historically, that's been around things like obstetrics or anaesthetics or emergency departments, all of those areas that are very procedural. But the problems that face our communities aren't all solved by those advanced skills. And increasingly, we're seeing mental health, aged care, and paediatrics, palliative care, those skills being needed by advanced practitioners in our region. Today, we're very fortunate to have someone who has shared that vision and has seen a need and gone about gaining the advanced skills as a rural generalist to meet that need. Not only meet it, but meet it in an outstanding way, such that she was recognised nationally for that work by the New South Wales Rural Doctors Network in a meeting in Canberra just recently. Dr Corin Miller is a rural generalist with advanced skills in paediatrics, an area that we dearly need here in the Riverland, and an area that we're looking to develop advanced skill training in this region over time. So it's with great pleasure to introduce Corin and hand over to you, Corin, and we're looking forward to hearing your experience, not just about what you've done for the community, but how much fun it's been along the way. Thanks.
Thank you so much for the introduction, Paul, and also thank you, Ray, for the opportunity to speak. I'm hoping that my slides work. So the title of this talk is Rural Generalist Paediatrics, How to Carve Out Your Niche and Have Fun for a Living. Did my slide change?
Perfect.
Okay. So good salam Wujulali, which means hey friends in the Thawa dialect of the Yuin people on whose lands I live and work. I'd like to acknowledge any Aboriginal or Torres Strait Islanders here with us online today, and acknowledge elders past, present and emerging. So if you haven't come across Dr. Glaucomflecken yet, you really need to. So definitely worth Googling, and the link's there. But he has these different characters. He's an ophthalmologist, but he has these different characters that he plays. And so the ones that I identify with most strongly are the rural doctor, which is at the top of screen, where it says, I asked him to rate his pain on a scale from 1 to 10, and he just said, I'm here, ain't I? I don't know what that means. That's the med student. And the rural doc is saying, that's because you're using a scale for normal people. You've got to use the farmer pain scale. And I'm here, ain't I, equals color crossbone. Not good. I've done a fair bit of work in emergency and definitely had some delayed presentations. We know that rural people tend to have worse health outcomes across the board, and part of that is difficulty accessing the health system. Now, on the bottom left with the purple background, that's his family physician or GP character, who always looks a bit frazzled and is always very busy. And then we've got the paediatric side of things, and this says, is this your first paediatrics rotation? I was going to attempt to play the video for that particular clip, but videos and me and presentations never go well, so you'll have to look it up. But essentially, the paediatrician is wearing unicorn horn ears and stickers on his face. And the med student is like, have you already been seeing patients? And he's like, no, why? Anyway, so to be a rural generalist pediatric, you need to do your usual rural generalism training, and then you do your ARST in pediatrics. So to tie this back to the title of my presentation, a niche is a comfortable or suitable position in life or employment, and I feel like I've found mine. To have fun is amusing, entertaining, or enjoyable, and to make a living, so an income sufficient to live on or the means of earning it, or more simply, and this is my favourite one, alive. So to me, this is my favourite definition of success over on the right. To laugh often and much, to win the respect of intelligent people and the affection of children, to earn the appreciation of honest critics and endure the betrayal of false friends, to find the best in others, to leave the world a bit better, and to know even one life has breathed easier because you have lived. This is to have succeeded. This is something that really spoke to me, and I try to live my life this way. So how did I end up doing what I'm doing? A whole lot of luck, a whole lot of hard work, and according to the literature, also possibly some personality traits. So rural GPs were found to be higher in the temperament traits of novelty seeking and lower in harm avoidance. They tend to be highly self-directed, caring, cooperative, objective, and persistent. I like all those words, so I claim that one. In particular, GPs who intended to leave rural practice had significantly higher harm avoidance. So again, we're looking at a subset of the population that would be completely bored if they were in the city doing the same thing over and over. I would hate to be a renal physician in the city, for example. I have friends who are GPs in the city, and I hear stories about what they get up to, and I would not like to do that. So instead, I get to do what I love to do. So there's a whole lot of work to be done. Paul mentioned the desperate need for paediatrics in rural areas, and this is just one health outcome that I pulled out of the literature, but pretty much across the board, rural people have worse health outcomes when compared to urban people. And then if you look at the breakdown, so on the left, is the Australia does quite well internationally when we're looking at our health system and health outcomes, if we're looking at an average for all Australians. However, if you zoom in, you see that actually there's a whole lot of inequity there, and we need doctors like yourselves to help fill that gap. So as you can see, if you're Indigenous or if you live very remote, your health outcomes are nowhere near that average. So with regards to paediatricians, consultant, non-GP specialist paediatricians, less than 1% work more rurally than outside large rural towns. So we know that nearly a third of the Australian population lives outside major metropolitan areas, and the percentage of paediatricians and other specialists and allied health and lots of other, pretty much everybody except GPs, the access to these health specialists dwindles the further you get away from cities. With regards to GPs, 75% work in major cities, but compared to pretty much every other health provider, I think pharmacists is the only other one that comes sort of close to GPs, but we are relatively better distributed across Australia. When you're rural, we have a much broader scope of practice than those GPs working in the city, and that's where we have the opportunity to strengthen the health system and also to improve health outcomes for our population. So this for me is home. If you look at Eden on the left-hand side map, I don't know if you can see my cursor, but we are approximately 3.5, or actually Eden's probably 4 hours away from Canberra by road each way. We're approximately 7 hours away from Sydney and about 8 hours away from Melbourne. So we really are, although it doesn't look like we're that remote. We're actually a long way from any major city. The middle map was the Black Summer 2019-2020 bushfires that heavily impacted our region. And Eden, that's a little bit further south than me, about 25-minute drive from where I live, they were directly impacted by fire. It's terrifying. But you can see that from Bateman's Bay, which is number 6 on both of these maps, if you draw a line straight across, you pretty much get to Canberra, which is ACT. So different territory. There's some cross-border issues there. But if you draw a line from Canberra across to Bateman's Bay, the rest of that territory heading down south is the coastal Monaro region, which is where I work. It's approximately 30,000 square kilometres, and we have about 20,000 young people, so under the age of 18, fairly sparsely distributed. If you look at the pie chart, I'm not a great fan of pie charts, but this one, I'll make an exception. We have more than 80% of our population being either moderately or highly socially disadvantaged. We have a large proportion of single parent families. We have a large proportion of Aboriginal population. We have a large proportion of those in the lowest quintile of socioeconomic disadvantage. And if you look at this map on the far right, that's Aboriginality. So Eden, along with a stretch up north slightly, has a relatively high Aboriginal population. Now, the nearest Aboriginal medical service is 100k round trip. They're located up in Bega. So we have significant barriers to care for this population. With regards to the paediatric service, back in 2014, you can see in the little box there that about half of our inpatients actually got transferred to Canberra, and only 22% stayed locally. If you draw that line from Bateman's Bay straight across to Canberra, south of there, we had 0 paediatricians, none. And so all visiting outpatient clinics came from Canberra, and all up, they saw about 200 children a year maximum. And this is just a little timeline here. Sorry if it's a bit busy, but in 2014, there was a GP-run service in Bega. SERH is South East Regional Hospital. All outpatient clinics via outreach from the ACT. Around 50 to 100 consults in Bega annually, and around 100 consults in Cooma, which is just up the mountain a bit, annually. And over time, the service has grown and grown, and we've gone from strength to strength, but it hasn't been without hiccups along the way. So we got our very first consultant paediatrician back in 2019. And we established outreach clinics across our patch. It was a great time. I learned a lot, and that's when I completed, most of my really intensive paediatric training. Because in 2020, we were largely a locum and consultant paediatrician-run service, with me kind of tagging along and filling some of the shifts. But when the pandemic hit, none of our locums could get there. So it was me and one consultant paediatrician filling the roster. After a while, the paediatrician left. So it was just me and some locums that could get through for a couple of months. And then from then, when the pandemic sort of settled a bit, we've managed to, as a team, build an amazing service. So we've now got 4.6 full-time equivalent staff specialist paediatricians. I've dropped right down with my hours because I'm currently doing a PhD. That's a whole nother topic of conversation. We've also managed to get junior medical staff, which is huge. And instead of doing 200 clinic consults a year, we're now doing that a month. So what happened? Well, initially, the paediatric outpatient clinic was seeing nowhere near enough patients. And so as a population, we don't have that many inpatients, say, But we have so many outpatients that have never had a health service to tap into to get their needs met. And so particularly with regards to children with developmental, behavioural, mental health or learning concerns, we know that last year, when I crunched the numbers, they made up over 70% of our waiting list and 49% of our active patients. So there's a huge unmet need there. At that stage, we're receiving approximately 6 to 10 new outpatient clinic referrals a day. And the waiting time for triage category 1 was 30 days on target. You know, we would see all of the really sick ones straight away. But all of those non-urgent children, such as those with likely neurodevelopmental concerns, mental health, anything else like that, they could wait an indefinite amount of time to get their issues sorted. So this is when I realised that the current health system is not able to meet the need, and we need to innovate and integrate to be able to do better. So in terms of equity, we know across the board that rural people do not have health equity with their urban peers. It's complicated, there's lots of moving parts, and those that are most in need of assistance often fall through the gaps. So an example is the rural children are 3 times as likely to be developmentally vulnerable in their first year of school, but are the least likely of our population to be able to access integrated allied health supports to address that. That makes me cranky. So when my child in kindergarten was struggling and needing some help, I was ashamedly standing up on the box there, right? Because I'm privileged. I have a job, I have transport, I can pay, I can organise myself to get my son to care. And I saw the dramatic improvements in his health, wellbeing, educational outcomes from having that early intervention, which we know has the best evidence base behind it. So what do we do? Again, I don't know if you can see my cursor, but if you see the little boy standing down in the dirt, how do we get help to that child? Why is it that you need to be privileged to be able to access healthcare? That's not okay. So I love a good inspirational quote. You'll get used to me eventually, but the standard you walk past is the standard you accept. And this standard where I could get my child help, but almost no one else in my community could do that, and they were waiting an indefinite amount of time, that to me, not good enough. So we came up with a model of care whereby we were attempting to reduce the silos between care providers. So the children and families in the middle of this orange diagram, they're the same children and families. It's just that we're in our silos doing our little bit of the puzzle. And that's inefficient. And in a rural area where we have limited resources, to be double handling tasks and missing others doesn't make sense. And so this is where we developed a horizontally and vertically integrated model suited to our local context. And at the top there, you can see Eden in that little pink thing there. That's the lowest quintile of socioeconomic disadvantage, so they desperately needed it. And this demountable building here is the wellbeing hub that the wonderful principal of Eden Marine High had created just before I came along. So she kind of built it, and then we came, which was wonderful. So Jingi Gujalagali means children's stars in the Thawa language. At the award ceremony, the poor hosts had to say this name many times. I can see them struggling, but children's stars, it's just beautiful. And the logo was designed by local Aboriginal students and staff at the school. And this mission statement is what we came up with. So it's very much a grassroots community engaged kind of model whereby we all came together and tried to make the most of the limited resources that we have. So this is the timeline, 2021. I wrote the model of care and started annoying people with it. I did that pro bono because there was no funding, so I did it anyway. We soft launched in 2022, and I realized that actually we need to be able to track and publish outcomes from this, which is how I got launched into research. Again, another conversation. 2023, we expanded to cover a network of local schools, so 6 schools total. And this year we're focusing on scaling up to additional sites outside our direct patch. We've formed a research consortium, and we're in talks applying for larger grants, and our Eden implementation evaluation is underway. So never underestimate the power of a small group of people to change the world. In fact, it's the only way that it has. Like I said, I love a good inspirational quote. This is my team and I at the award ceremony, and that's one of our clinic spaces. And it turns out that if you find a job you enjoy doing, you'll never have to work a day in your life. I have fun. I love my job. And apparently I pull the same silly face in most photos. Probably in the middle one with the mask on, I'm pulling the same face. You can imagine that. There's some references, and now I'm happy to take some questions if you have any.
Fabulous.
Thank you.
Children's stars. Thanks, Corin. And while people are thinking of questions, I'll put one to you. You described at the beginning that one of the personality traits of rural generalists is having a low harm avoidance. And the ones who leave have a higher harm avoidance.
According to that particular study that I haven't digested, but yes.
So my question to you is that harm to their patients that they're more willing to accept, or is it harm to themselves?
A great question, Paul. I'm happy to send you the article from memory. It more so related to the level of stress that the individual could tolerate, the level of uncertainty, the level of, you know, needing to figure it out yourself because you don't have a giant team in the next corridor, you know. That's how I read it. So novelty seeking is definitely a trait that I've noted in rural generalists that I've met. You know, we get bored easily. Otherwise, we may be a subspecialist, a partialist in a city consult room, you know, seeing the same patient over and over. Variety is the spice of life for me. And so I never get bored. People say, how's work? I'm like, well, I'm never bored. And also I get to play with kids and with toys and stuff. I'm like sitting on the floor playing with blocks, and yeah, I love it. I have a great time. Yeah, thanks for the question.
That's great. So while I'm looking for other questions, how have you been accepted by specialist paediatricians? So here's this upstart. Isn't she a GP? What's she doing?
Just a GP, exactly.
So how have you managed that relationship? Huh?
Well, it's interesting because I didn't get hired as a rural generalist peds. I got hired because I was working in emergency. That's how I got my contract. And then it so transpired that they realized that they needed me in pediatrics. And so it's always been a matter of, you know, our LHD has this very much, you know, specialist and not GP model. And then lots of locum workforce because they can't fill the roster. So be that as it may. I've been with this service since its inception, pretty much. So a couple of years after the idea of it started to form, I've been there. And so I think a lot of the paediatricians that I've worked with have been surprised, and I've had lots of them say things like, oh, I didn't expect you to know so much about this. And I'm like, yeah, cheers. Obviously, I'm not a consultant paediatrician. There's certain things that, you know, I definitely don't know. I don't really want to resuscitate a 24-weeker if I can get someone else to do it, you know. But particularly with the community side of paediatrics, it's a passion area for me. It's something I've built a lot of expertise in, and now I actually often have consultant paediatricians that are more used to acute medicine. They come and ask me for my advice about what to do about this child with likely neurodevelopmental issues. So, you know, it's give and take.
And it's, for me, as though by initiating this as a rural generalist, you've actually increased the number of specialist paediatricians in the region.
Yes.
So it's really benefit.
Exactly.
Janaea, I can see your hand up.
Yes. Hello. Sorry,
Hi.
I'm in the car. I'm parked, I promise. So I'm postgrad year 2, and I've known pretty much since beginning of med school I wanted to work in the country, probably as a GP. And then in the last couple of years really went, no, I think like GP paediatrics is where I want to be.
Welcome.
So thank you. So like last year with your like award announcement and things, I was reading up about that and the program that you're running. I'm curious, as someone who's just at the start of my career, do you have any tips for sort of skills to pick up or things to pursue in these first few years while I'm still in my early like rural generalist training?
Yes, absolutely. Thanks for the question. There's something called the Sydney Child Health Program, which is run through. Are you aware of that?
Yes, I'm doing subject 4 at the moment.
Amazing. Definitely start with that. So I didn't think I wanted to do pediatrics because kids were scary. And I started with that course, which was called a diploma in child health at that time. But I started with that and then I just figured out that I loved it. And so I did quite a bit of emergency medicine. I think that's really important because if you are, you know, practicing as a RGPs and you don't have a paediatric service nearby, you do need to know how to resuscitate a neonate. You do need to know those, you know, pointy end kind of skills. And then other than that, I think just tell people that that's what you want to do because you start to meet people who are like-minded. I'd love for Paul or whoever to share my email with you if you're interested. I'm happy to stay in touch. But yeah, starting with that course and then trying to pick up as much acute pointy-ended type pediatrics as you can while you're still in the hospital system. Yeah, and I'd be happy to chat later if you have any questions.
Oh, that would be great. Thank you. Appreciate it.
No worries.
I think I can see your car travelling east for a road trip, Janaea.
I was in Bateman's Bay for the John Flynn program back as a student. So to see that you're on South Coast, New South Wales as well was felt very familiar and positive. So yes, I will definitely be hitting up your email.
Amazing. Sorry, Paul, but I might poach her. No.
We still haven't given up on poaching you, Corinne.
Thanks, Wayne.
That's more convenient for me.
Wonderful.
Corinne, you've obviously developed a really good relationship with the school. Now, kids are at the school, they're minors, their parents are not there. How do you manage the consent issues in a school?
Yeah, so the way that my clinic works is that I only see children and young people that are referred in by the school, so by the learning support teams, that kind of thing. At this point in time, it's not a drop-in clinic like other school-based models are, like the Victorian doctors in secondary schools, etc. It's something that I'm working on. I've actually got a nurse practitioner who is keen to do that side of things. But at this stage, it's been a matter of you have your parent or caregiver with you to be able to give consent, except when I've had the 17-year-old that no longer lives with their parents, they can demonstrate Gillick competency. You know, there's certain things that I'm not going to insist that we bring their parent or caregiver along for, but it's utilising the Gillick principle very much.
It's fabulous. Hayden, or Hayden with a light but no person. And no microphone at this stage.
Oh, there he is. Or not. No, maybe.
Are you wanting to ask a question, Hayden?
No. Just doing a cameo.
No, sorry, my phone keeps dropping out of everything and keeps trying to reset everything. I'm just here enjoying listening for now.
Thank you.
Thanks, Hayden. So we are at time. It sounds as though there are a lot of other people who would love to pick your brain, Corinne. I think people can see why the New South Wales RDN saw in what Corinne has achieved something that's worthy of a national award.
Well, I don't know. I still have imposter syndrome about it. It's normal apparently, but yeah, thank you for your kind words.
We've certainly appreciated the sharing that you have given us today, the inspiration that you obviously are to some of our junior doctors and some of our not so junior doctors as well. And I get a sense that part of the joy you get is by seeing the impact on all those young lives that are part of your community. And in the end, isn't that why we're all here?
Absolutely, yeah.
People. So, Nakan, everyone, thank you for joining us again for the Riverland Academy of Clinical Excellence Grand Round. We look forward to seeing you next month. And thank you, Dr. Corin Miller.
Thank you so much. Bye, everyone.